What was the purpose or need for this study?
In inflammatory bowel disease, patients are at increased risk for precancerous and cancerous lesions in their colon. They undergo surveillance colonoscopy in order to find these lesions at an early stage and facilitate endoscopic removal. With increasing fidelity of endoscopes and advanced imaging endoscopic techniques, more and more lesions are being visualized. Our current guidelines recommend standardization of nomenclature to describe these lesions. This is using either the Paris classification or the modified Paris classification. However, in our clinical practice and in our previously published research, we recognize that it is practically very difficult to utilize these current classification systems. So we decided to formally study the Interobserver variability in the application of these suggested classifications to both images and videos of IBD-associated visible colonic lesions. Also, definition of the border of these lesions is an imperative feature determining endoscopic resectability. And so it is crucial to be able to be reproducible and have high agreement. This was another feature that we studied in this study. We also chose to assess readers' assessment of whether these lesions were dysplastic or not while looking at the images. And we attempted to find a correlation between particular morphologies and predicted and true histopathology.
What is the known agreement of the Paris classification in non-IBD polyps?
In non-IBD polyps, a study published in 2015 showed only moderate inter-observer agreement for the Paris classification. This was a study performed in 85 polyp videos with a kappa score of only 0.42. In IBD, there is often background mucosal inflammation and a higher variety of polyp morphologies and histopathologies, making application of the Paris classification even harder.
How did you perform this study?
Our center performs a very high number of IBD surveillance colonoscopies every year, often with advanced endoscopic imaging technologies such as narrowband imaging or chromoendoscopy. Out of these cases, we identified 100 high-definition images with well-defined histopathology. There were 42 dysplastic lesions, including adenomas and cancers, 33 non-dysplastic lesions, including pseudopolyps and hyperplastic polyps, and 25 serrated lesions, including serrated epithelial change. We also created a set of 30 videos with varied polyps in them. 10 senior and 4 trainee IBD endoscopists then rated each image and video using a Paris classifier, a modified Paris classifier, whether the border was distinct or not, and they estimated the size and predicted the pathology of each polyp. Readers received images in a randomized order, different for each reader, and they were blinded to each other's ratings. We then measured agreement for each category.
What were the main results of your study?
Overall, there was poor consensus for both the Paris and the modified Paris classification, with kappa scores of only 0.42. For both classifications, the lowest consensus was for lesions that were either 1S or 2A or mixed in the Paris category, or sessile or elevated for modified Paris. The difference between these categories is lesser than or greater than 2.5 millimeters in height of the lesion. Our results show that this assessment of height of the lesion is very difficult to standardize. We also showed that these were the lesions that were more likely to be predicted as dysplastic by the readers and more likely to be confirmed dysplastic on true histopathology. And so this raises the question of whether there is a need for this differentiation in height of lesions while trying to classify the morphology of these polyps. Another result was that size estimates were more variable with an increasing size of the lesion. And as one would expect, border distinction was higher when people viewed videos as opposed to images because they were able to visualize the lesion in multiple dimensions. Another interesting result was that the morphology of pedunculated lesions had higher agreement among readers, and these were more likely to be non-dysplastic in true histopathology. Most of these were pseudopolyps. For non-pedunculated lesions, endoscopists did tend to overpredict the true dysplasia in the lesion compared to ground truth histology, both in images and in videos. Of the overpredicted lesions, most of these were serrated lesions that on true histopathology. Flat lesions, which are either Paris 2C or a modified Paris flat morphology, actually had a lower odds of dysplasia. And when we looked at these lesions, many of them were serrated epithelial change or hyperplastic polyps. This is an important point to remember when you consider older studies often suggested that flat dysplasia was a predictor of progression to cancer. But though in those studies, flat dysplasia referred to what we currently call invisible dysplasia and not the lesions that we can currently identify with high definition scopes.
What are your main takeaways from this study?
This is the first study to demonstrate interobserver variability in the Paris and modified Paris classification for IBD-associated lesions. And we show moderate to poor agreement for both of these classifiers. This raises the point that we need to have better methods to standardize endoscopic description of visible lesions so that we can make better recommendations on management strategies. We also demonstrated poor agreement between predicted and true histology based on the morphology of lesions. And here we believe machine learning, once developed with large and varied data sets, especially once it's correlated with ground truth histopathology, will be able to solve some of these problems. We hope to continue to work with our large data set to develop such algorithms.